This week on the BackTable Podcast.
What's going to happen is artificial intelligence will continue to improve. I think some of the stuff I'm seeing out of some of these companies, out of these startups all over the world, you're seeing them, they're getting better than the human expert at picking up things. So I think what it's going to do personally, I think in 5 years, you'll have a center like my hospital, your hospital, where every CT head is going through some sort of artificial intelligence and it's flagging, right? If it's suspected elbow, it's flagging and pushing it. If it's ICH, it's pushing it. So what is that doing? It's pushing it, for example, to me, it's pushing it to the neurosurgeon. And then for, all the mammograms, it's flagging, these 25 cases out of the 1,000 that were run through. And then a radiologist will review those 25 cases. I actually do believe that's the way it's going.
Hello, everyone, and welcome to the BackTable Podcast, your source for all things endovascular. You can find all previous episodes on our podcast or on iTunes, Spotify, and backtable.com. This is Sabeen Dhand as your host this week, and I'm very excited to introduce our guest today, Dr. Ameer Hassan, coming to us from the Valley Institute of Neurological Sciences in Harlingen, Texas. Welcome, Ameer.
My pleasure.
Before we dive into our topic today, just want to say a quick word from our sponsor, RadPad. RadPad was developed by physicians for physicians, clinically proven radiation protection during cine and digital subtraction angiography. Don't bet your career or your health on anything less. Trust RadPad Radiation Protection Shield for all your fluoro-guided interventions. See radpad.com for more information. Contact info@radpad.com for a free radiation evaluation and a no-brainer radiation protection cap. Make sure to let them know that you heard it on BackTable Podcast. So, Ameer, you're a pioneer in neurovascular therapy, and you're actually the president-elect of SVIN. Can you give us a little background of yourself, and how did you become one of today's leader in stroke therapy?
Oh, so it all started when I was a little boy. No, I'm just joking. I've always wanted to be a physician. And what's funny is I have, my godfather and people in my family are mostly plastic surgeons. And I always liked neuro. And, for me, plastics it was a little too artificial, let's say, no pun intended. But, going to med school and working under Dr. Adnan Qureshi, who is my mentor, was my mentor during fellowship and training. We keep in touch. He just opened my eyes to a new field that was just starting in the early, really, they were doing, the things that we do for the heart and the brain. Mercy wasn't even developed yet. I saw the first Mercy device as a medical student. I got to see the evolution of this stuff really from its infancy. I went to the first SVIN meeting ever. I was still a medical student at the time. So, I got in early. I really had a love for it. And it was just seeing that patient-physician interaction. So when coming out of my, plastics rotations in medical school, nobody's ever completely satisfied. And I saw, Dr. Qureshi treat somebody, and next day we go around on this patient, and, the family's hugging him and they're all happy, and the NIH dropped significantly. I was like, I want to do this. I had a grandfather who died of stroke, completely debilitated, bedridden, and then died a few months after his stroke. And, we can make a difference. And ever since then, they say like the stars aligned, and Jay for neurology. And then Qureshi moved to University of Minnesota. So after I finished neurology residency, I went there for stroke, neurocritical care, and endovascular fellowship, and then decided to go to a place where there was no endovascular program. I wanted to go to an untapped market, somewhere where I could make a difference for a population. I didn't want to go to a major city where there's already, 5, 10, 15, 20 people doing this. Now, some major cities have like 40 people doing this. So this found the Rio Grande Valley. Dr. Parada was willing to take a bet on a crazy guy like me. She had built the first certified stroke program, and she wanted to make it into an endovascular program. And she had offered to one of her friends who was currently in San Antonio, who still is in San Antonio, and he just, couldn't move down to the Valley. And I came, and, we quickly built a program that was expected to only do 40 cases the first year. By the third year, they expected us to do 120 cases. We did 440 cases my first year. We do over 1,200 cases a year now, over 200 mechanical thrombectomies. We're one of the busiest wingspan shops in the country, one of the biggest ABM shops in the country. First CSC to put artificial intelligence, install Viz AI in a hub and spoke model in Texas and the Midwest. So yeah, we've had a lot of firsts. We were part of Swift Prime, part of Dawn. It's one of the reasons why I work with all the device companies, because they all really believed in us early on. I wasn't even a year into the program, and they saw like, who's this upstart who's using solitaires like there's no tomorrow, and they came and they offered me a spot in Swift Prime, and it was really nice. So
That's awesome.
we work with everybody. We're equal opportunity, and we just love everybody.
That's great, Ameer. I mean, congratulations on all the work you're doing. Seriously. I mean, you guys are definitely just moving and paving the way for stroke therapy. I mean, you mentioned hub and spoke model. What is a hub and spoke model?
So typically your hub is a program that can offer all of the neurosciences, treatments, neurosurgery, subspecialties, neurocritical care, neurology, vascular neurology. So for example, we are a CSC. We were the first CSC south of San Antonio, and we accept transfers from hospitals. And these are from Corpus all the way to Laredo and everything down to the Mexican border. Now, spokes are those 11 hospitals. They're all primary stroke centers typically. Some of them were not even primary stroke centers and now have become primary stroke centers. And they will transfer to you all your subarachnoids, intracerebral hemorrhage, anything that needs a higher level of care, that needs neurosurgical, neurointerventional, or neurocritical care services. Typically, your hub also is a research hub. We have stroke studies, aneurysm studies, endovascular studies, new device studies, NIH-funded trials, device company-funded trials. So your hub is usually your one-stop shop, but geographically, it wouldn't make sense to have a bunch of hubs, and that's why I think the hub and spoke model works in a place like South Texas, where it's a 1.3 million in catchment area. And now there are multiple CSCs, actually. Some of them opened about 40 miles west of us. And we actually cover one of them. The other one is kind of like an island on its own. They do their own thing. But between the two CSCs we cover, we're covering now 10 of those 11 hospitals and 10 of the 11 primary stroke centers.
Wow. So basically your hub is like an anchor establishment, and these spokes are these secondary establishments that transfer to the hub. You said you have 11.
Yeah, they're the closer center, right? Right.
Yep.
You're going to call, we're trying to educate everybody, be fast or fast. And the T is time to call 911. So these people need to just call 911, get to the closest emergency room. And then when they're 35 miles away, they shouldn't be coming to me. They go to the primary stroke center, and then they get transferred to a CSC or the hub.
So, at these primary stroke centers and your hub, I mean, how are they communicating with you? Are they using telemedicine? How are you finding out about these patients? Do they have their own endovascular specialists or stroke specialists, or how is that getting to you?
So that's a great question, because they actually are all different. One of the shops in Corpus, for example, they have a board-certified stroke vascular neurologist. They actually have an endovascular guy who only does 2 weeks of call. So it's 2 weeks off call. They transfer everything to us. There are places like the primary stroke center that's down the street from us. They don't have any neurology coverage. And what they'll do is their ER, they use like a SOC type of telemedicine service, teleneurology service, and they know that we are their CSC. So anything that's too high level for them, they basically call us. They have a one number to call, and the tenant transfer center will figure it out and call whoever's on call, whether it's me or my partner, Dr. Techley, and they will transfer the patient to us. There are other centers, for example, in Brownsville, that's a sister hospital. It's also owned by tenant. So they have AI. So for them, they have their own stroke neurologist, and everybody's involved in the decision, but we get the images immediately. We get the push alerts for the large vessel occlusion alert, and things have improved significantly. And we'll talk much more about that later during the AI session.
Definitely. So you mentioned it's just you and another person who at your main hub that's doing stroke intervention?
At Valley Baptist Medical Center, Valley Baptist Neuroscience Institute, it's myself and Dr. Techley. Dr. Techley was my junior fellow at University of Minnesota. And then after I moved here, I quickly saw how busy it was, and I brought him over. He's a great guy, great partner, definitely a brother in arms in more than ways than one. And then we actually trained somebody who now helps us cover, Dr. Georgiadis. He helps us cover McAllen Medical. So he's there for like 17 to 20 days a month. And then we help cover the days that he's off. So it's 3 of us covering 2 CSCs.
and busy ones. Busy CSCs.
Yeah, it's not for the faint of heart. Let's just say
No,
that.
not at all. Impressive work that you're doing. I mean, these EMS brings the patient to, one of the spokes or the hub. Now, how do they know, what do they use to kind of determine where to go? I mean, they see a patient who has aphasia
oh
or
yeah, no,
whatnot.
this is in Texas. It's really good because we have these tracks, right? So we're the track, which is the Trauma Regional Advisory Council Section V, and the Houston market, Dallas, San Antonio, they all have their own. And so for the Rio Grande Valley, we sit on the track V. I was a previous chair of the stroke committee. Dr. Parada was before me. Dr. Techley is the current chair. And what you do is you sit with all of the hospitals and you work with EMS. And the idea is the stroke committee said, okay, we are going to create this transfer algorithm for all EMS. And it was originally based on the RACE score. So RACE was a score for Friends of Barcelona, and based on whether or not the patient had weakness, aphasia, neglect, they tally up these points. And if it's, for example, a RACE score of 5 or greater, you would bypass a primary stroke center and you go straight to a CSC if it's within 30 minutes. Otherwise, you just go to your closest institution. Then I actually invited Dr. Taleb, who invented the VAN score, to our South Texas Stroke Symposium. We've been doing it now for 9 years. We got to bring you down, man. It's actually a good meeting. It's a 2-day meeting. First day is focused on stroke. Second day is on all endovascular stuff.
That's great.
And then the second night, we actually do a black tie event. We call it the Red Ball, and we raise money for stroke awareness. So very cool stuff. And my wife is runs the foundation, the Stroke Research and Education Foundation, to keep the money local. And then we do the nonprofit itself does fast billboards, be fast, things in Spanish and English, PSAs and stuff like that. Back to the question. So then we switched to a van. So track decided, right? The members, not myself, not Dr. Techley, nobody. It's as a committee, they said, hey, we love this van thing, and EMS is so supportive. We also invite EMS to our symposium. We want to switch to van. So about 3 or 4 years ago, we switched to van, and ever since then, it's like van positive or van negative. If it's van positive, you bypass the primary stroke center and go straight to the CSC if it's 30 minutes or less.
That's great. Yeah, you guys have your stuff down. I mean, for our hub and spoke model, I mean, it took a while to educate EMS, locally here in LA. And it's amazing that your guys' system is so clean cut. I envy that for sure. Then if they don't go to your hub and you have transfers, this is something that we deal with a lot. How do you optimize the transfers from your spokes to your hub? So
that's very interesting. So we spent a lot of time working on how to improve every single time frame, right? Mm-hmm. Groin to recan, angiosuite to recan, CT to recan, door to recan at the primary as well as the CSC. And in all of our research we've done, the biggest problem, especially at spokes, and until now, even with AI and how we've been able to improve the times, EMS is one of those pieces that unfortunately we haven't been able to improve significantly. So for the patients who do show up at our door directly because EMS did bypass, we know based on Stratus data that was published in Circulation, I'll be presenting about this next week at ESOC using the complete data, the complete registry, the Penumbra study, looking how direct patients come so much sooner than if you go into your typical, hub and spoke model where they can then get transferred to a comprehensive stroke center. And in both those studies, the difference is about an hour and a half. So there's a significant delay in treatment if the patient ends up going to a primary stroke center first. Now, in some cases, you can't do anything about it, right? If they go to Corpus, the patient's in Corpus Christi, it's a 2.5-hour drive, it's an hour flight, a 40-minute flight by chopper, that they're not going to bypass, right? They have to go to that center. And then they'll find out that, nobody's call here, they're going to triage the patient appropriately, and they transfer to us. What we're finding is in the places that do have artificial intelligence and, for example, Viz AI in our Brownsville location, which is about 25 miles away from us east, they are significantly improving primary stroke center imaging to CSC door and CSC groin puncture time. And we just had a paper published on this topic in Interventional Neuroradiology, I think a few weeks ago. And, early experience with artificial intelligence. And what we're finding is that these patients with artificial intelligence, you bypass so many things that occur in a hub and spoke model. And if we have the time, we could just dive into it right now.
Yep.
So basically, in our institutions, most of our spoke centers have this painful process. And when I say painful, it's painful. So let's say, patient comes in, potential large vessel occlusion. What they'll do is EMS went to them because it's more than 30 minutes to me, let's just say. And then they get the patient. Now, the good thing is most of these programs, because they work very closely with us, they know, hey, NIH 6 or greater, we're going to do a CT angiogram on this patient. Okay, good. So they evaluate the patient, they take in the CAT scan, they'll decide whether or not to give TPA, then they'll go to CT angiogram. The radiology tech has to reconstruct the images. Radiologist has to read. After the radiologist reads the images, he calls the ED physician, who calls the neurologist, who calls the CSC on-call interventionalist, myself or Dr. Techley, for example. Then I'll say, yes, great case, yeah, send him over. Then he has to call the house supervisor. His house supervisor calls my house supervisor, who then calls me to tell me, hey, Dr. Hassan, have you accepted this patient? And then says, go ahead, and then the patient is transferred. See the number of steps? It's pointless.
Oh, yeah, no, I mean, exactly. Like those are multiple steps. Each one, even if it takes a couple minutes, I mean, they just add up. And every minute counts time in the brain. So
time. Oh no, right? That 2 million neurons a minute. 1.9 million neurons a minute ages your brain by 3 weeks. So we know time is extremely important. So, and you and I know, based on the Dawn and Diffuse 3 data, right? Yeah, there are your fast progressors and your slow progressors, but without knowing the patient, he could be a fast progressor. So you always have to assume the worst, and the patient's a fast progressor. We need to move quickly. So in our data, we actually looked at November 18 to May 19, which was when we installed Viz. And then we looked at the prior year data at, pre-Viz data. And we compared all the transfers from Valley Baptist Brownsville to Valley Baptist Harlan. And we showed it dropped from 171 minutes to 105 minutes from CTA at the primary stroke center to patient arrival at the CSC, door time. So we're talking 66 minutes saved. Yeah. This was huge. And that directly correlated to good outcomes, right? 55% neuro ICU length of stay reduction, 3.5 days. The money-wise, you're saving a lot of money for the hospitals, right? Because hospitals always think about money. Let's be honest. They have a duty to serve, but they have to be profitable. I mean, it's a business.
It's a business. Yeah.
It is what it is. So if you're getting a DRG for mechanical thrombectomy, if you can shave off 2-3 days off this patient's admission, that's money in your pocket. So it's for us, we're really excited about it. We continue to look at all the ways that this is benefiting patients. We have a lot of cool stuff. So this data was presented last year at ISC, International Stroke Conference. It was just published recently in Interventional Neuroradiology. We have 3 abstracts looking at AI, whether it's hub and spoke or directly at the CSC, all being, presented this year. They're all submitted, so we hope they get accepted at ISC this year. And we're really excited about AI. We really do think this is the future of stroke care, and we will continue to improve outcomes.
That's great. I mean, just for some of our listeners, I mean, we're throwing out the words artificial intelligence. What is that? What is Viz? I mean, is it a bunch of Terminators going around diagnosing stroke? Like, what is artificial intelligence in stroke?
Okay, so no, great question. So let's take a step back first. So I don't know, I love to give talks about artificial intelligence because it's, there's a recent evolution of it, and artificial intelligence was actually developed in the 50s. Okay, it enabled computers to mimic human intelligence, but what they did is they had to make decision trees. That really was just a broad range of artificial intelligence. Then in the 80s, you had machine learning. So you had a subset of artificial intelligence enabled the machines to identify statistical patterns, and that's where your games came in, right? Like how you start playing poker on your computer or chess, based on stats, statistical patterns, the machine, plays against you. Today's artificial intelligence is really deep learning. So it's a subset of machine learning, and it's enabling the machine to train itself. And what we're seeing is the deep learning is AI enables a system to learn from the data compared to programming, which was the original artificial intelligence in the 50s and the machine learning of the 80s. Today's artificial intelligence is deep learning. So it's learning from the data and then continues to get smarter. And looks for things. So let's get into, if you don't mind, we could
Yeah.
give you a little 2-3 minutes about deep neural network. So deep neural network or convoluted neural network, this is a way to teach a system. So for example, let's take facial recognition, right? We're not going to use stroke. So facial recognition, you have these images, right? The input layer. And what happens is your first hidden layer of this network is detecting, for example, geometric primitives. Then the second layer starts looking for complex features. Let's, thick eyebrows, big nose, your eye shape. Okay, that's the second layer. Your third layer starts detecting a general pattern for a face. Then the output layer, what it does is it detects the most abstract representation of a face. And that's how facial recognition actually works. So moving that now to Viz AI and current artificial intelligence in acute ischemic stroke is the machines now, the deep learning is getting better than a human expert. And it continues to teach itself, and it refines every time it looks at an image and knows that, hey, this was a stroke, this wasn't a stroke. It continues to learn and continues to improve. And now what it's doing is looking for these things. For example, the AI currently in acute ischemic stroke is really just focused on alerting a physician if it finds a large vessel occlusion. That is the AI. The CT portion, CT perfusion, the automated CT perfusion mapping, the view of the CT, the Viz hub, like the HIPAA compliant messaging tool. Rapid has similar features of all these things. All of those things are really not artificial intelligence. It's the Viz ELVO, the Viz large vessel occlusion detection. That is really detecting a suspected large vessel occlusion, pushing like an alert to your phone or your Apple Watch. That is really the AI. That's the immediate activation of the emergency stroke systems. There's very good papers out there comparing, Brainomics and Rapid and Viz AI. It's shows you that, yeah, all of these things are called AI, but the only one that's actually using AI is Viz. And it's using it as a, AI independent thrombectomy activation. And that's the way we use it, right? We use it as, hey, I got this ELVO alert. Let me go look at the image. Oh, look, Brownsville's got a large vessel occlusion. And then boom, I'm messaging the group on the Viz Hub. I'm calling them. Hey, one of our neurologists over there, Dr. Gaitan or Dr. Sardan. Hey, buddy, what's going on? I see this. Yeah, Ameer, we got this case and XYZ. Okay, we're transferring the patient to you now. And that's it. I mean, we just bypass 7 steps. And the patient comes to the CSC much faster.
Exactly. I mean, that's that, I met you in person a couple, maybe about almost a year ago now when we were just getting Viz AI at our hospital. Mm-hmm. And I mean, yeah, it has removed so many steps from all our spokes as far as getting the images, reviewing them. We're not relying on other radiologists to look at the imaging. I mean, you're looking at yourself. You can even plan the case, and
oh yeah, you can look at the arch and look at the neck, of course.
Exactly. Yeah. And I think we've mentioned some of the platforms. Viz is definitely the one we use. I mean, Rapid is Rapid AI at all, or is Viz the only one using AI?
So technically the way you're getting these alerts to your phone is the AI. Now, I have Rapid at my center. I had Rapid at McAllen Medical before we got Viz installed a few months ago. So I had them both side by side for like a year and a half. And we still have Rapid here now at Mothership at Valley Baptist because a lot of the studies like Timeless, Select 2, you have to have Rapid. And so I get to see them both. What it does is it emails me, or if you have the app, it sends you the alert that a new study was done. It pushes the CTP image. It pushes, the automated aspects. It pushes what their vessel occlusion system looks like on the app or email. Whereas the step above right now with Viz is this whole push alert to your phone if it's suspecting a large vessel occlusion. That's what's making it unique. Now, do I think, Rapid and Brainomics and all these other things that are coming out, and even independent guys are working, pushing for grants and trying to make what's the word, like a free version that would be open source. Everybody's going to catch up. And what I like really the most about this is I was a big fan of Viz's CT perfusion, maps, because it automailed me, an analysis where I didn't have to depend on maybe a tech misconstruing some information or choosing what he thought was an artery or a vein. You know what I mean? Like, you remember how we used to build these
Yeah.
things early on. During my fellowship, it was painful. We had to build the CTPs ourselves. So having that automation really helped, but this like took it to another level. And now Rapid has improved a lot of their stuff. I mean, the app itself has improved tenfold over the last couple of years. You think it would have improved as much if Viz wasn't out there, or Viz wouldn't continue to innovate, like with now Viz Recruit and Viz ICH, right?
Yep.
Rapid is the first with automated aspects, so they have, I believe they have FDA approval for the automated aspects, right? So I think it's good. Innovation, is driven with competition. Yeah, you need the competition to drive this.
Absolutely. I mean, you think here's a question for you. I mean, do you think any of these apps can determine if a bullet pellet is in a basilar artery?
So that case was actually picked up as something is wrong, because it noticed that, right? You know how Viz works on the, so what it does is it uses an AI powered algorithm, and it's looking for, series identification using metadata, and it starts extracting, the head mask. It's imaging analysis, it's excluding things, it's registering what it thinks is the MCA and the M2s. It starts segmentation of these vessels. And then, hey, how come the right one stops here and the left one goes over here? And then it alerts you. That's initially how, via central, how Viz Elvo works, right? I'm obviously simplifying it significantly. I'm sure Chris and his partners are not going to be happy, but that's basically how it works, right? The center line measurement, and it's drawing out what it thinks is the MCA, or for, you know what I'm saying? So it's currently approved only for M1 is really where it's picking it up. Now it is getting smarter, but for the basilar tip case, that was, I'm called by my trauma surgeon. Hey, Ameer, can you come look at the CTA with me? I'm like, why?
Yeah.
So now, but to be honest, like, I'm sure you follow Waleed on Twitter and other people who are like, oh, AI is going to be the death of radiology. I mean, I don't think it's going to be that fast. That's like saying Corendus is going to replace me and you in 5 years. It's not going to happen. You and I both know that. What's going to happen is artificial intelligence will continue to improve. I think some of the stuff I'm seeing out of some of these companies, out of these startups all over the world, you're seeing them. It's right. They're getting better than the human expert at picking up things. So I think what it's going to do, personally, I think in 5 years, you'll have a center like my hospital, your hospital, where every CT head is going through some sort of artificial intelligence, and it's flagging, right? If it's suspected elbow, it's flagging and pushing it. If it's an ICH, it's pushing it. So what is that doing? It's pushing it, for example, to me, it's pushing it to the neurosurgeon. And then for, all the mammograms, it's flagging, these 25 cases out of the 1,000 that were run through. And then a radiologist will review those 25 cases. I actually do believe that's the way it's going.
Yeah, it's basically
to say that,
like an aid.
There's not going to be any diagnostic radiologist, that's absurd.
I mean, who knows what will happen in like 15 years? But I think I've seen
in 15
Viz.
years it could be different. I mean,
it could be exactly.
I'm just saying 5 to 10 years.
We're okay in that. No, I've seen the app. I can't even imagine how I was doing stroke and in a hub and spoke model without an app like Viz or Rapid. I mean, it's helped tremendously. What is the future? I mean, we kind of touched on it, but what do you think the future holds with AI and these apps? I mean, sometimes I think to myself, sometimes I get a call from the neurologist. He's like, look, this guy has a gaze preference and is aphasic and hemiparesis. I'm already calling in the team before the app is telling me anything. But where do you see these apps and AI and stroke in the future?
So I think artificial intelligence will continue to help us improve our hub and spoke models. It's going to significantly improve our imaging to groin puncture, imaging to recanalization times. I think it will help us to choose those patients on the fence, right? I think as a lot of these studies come out with lower NIH or distal branches, things like the Tiger 13 are going to, prove that we should be treating distal M3s with pretty good safety. So with Viz Analytics, we'll be able to visualize our workflow parameters, improve our door to needle times, door to device times, door to recanalization times. I think AI and all the tools that we're going to have in our armamentarium. We're going to continue to improve time, improve outcomes. I think we're going to be treating more distal lesions using a combination of large vessel occlusion detection and CT perfusion. I think you do need that CT perfusion element to decide to treat an M3. But on the other end, you have, people like Tudor who, hey, let's take everybody to angio suite directly. Every NIH 10 or 5 or greater, just take them straight to cath lab and do an angio and see what's going on. Mothership, I think things are right now in flux. There's going to be so much that comes out, which is awesome, right? That's why I love this field. And you and I both love doing what we do. It keeps us entertained, right? It's not boring whatsoever. I think for the primary centers that are going to transferring patients to the CSCs, I think that hub and spoke model will continue to improve. More hospitals will implement CT perfusion. More of the primary stroke centers will start doing CTP with the CTA. So that way they decide whether or not they need to treat these patients, whether or not they need to transfer them. More and more, we might be getting tenecteplase as a treatment, right? Yeah. It's just a bolus and go. There's no 1 hour drip with like the data showing, extending the window for IV thrombolytics and wake up strokes. Why should a patient who's going to be 2 hours away from me not get an IV thrombolytic? Hey, do a CTA. You found a large vessel occlusion, do a CTP. You find there's a huge penumbra, give them tenecteplase, and then transfer them to us. And if it opens up, great. The patient benefited. Yep. If it doesn't, then we're going to take them to cath lab. So I think it's just, there's so many moving parts right now, but AI is going to play a role in improving our, onset to recanalization time significantly in the hub and spoke model as well as the CSCs.
Yeah, absolutely. I mean, the stuff, we're buying 2 new fixed units in one of our hospitals. And I mean, Viz is integrated into the fluoro unit, even like on a Siemens Icono. It's there. I mean, these things are, it's very, very cool. And I'm really excited to see it. You're right. In neurovascular therapy, there's so many new devices, so much new developments. It's a very, very exciting field. And there's never a boring moment for sure. Yeah, well, Ameer, thanks so much. I mean, I think this is a really, really hot topic right now. And we really, really appreciate you coming on board and participating in this and teaching all our listeners about AI and stroke and hub and spoke. So thank you.
My pleasure. Thank you very much for inviting me. And hopefully next time we can get a little bit more into the quantum mechanics and the quantum realm and really go far out and figure out what could happen in 20 years.
Absolutely. No, thanks, Ameer. I really appreciate you coming on board.